Welcome, everyone, to our first World Society of Pediatric Ophthalmology and Strabismus webinar. Around the world, this is our new look, masks at home and gloves at home. But today, we're not going to be discussing coronavirus. Take off your masks, take off your gloves, and join us to talk about what we all love, helping others. And that is the ethos of the World Society of Pediatric Ophthalmology and Strabismus. Expertise resides all around the world, and our desire to help others resides all around the world. That is who we are. That is who doctors are. So welcome. One small housekeeping as we start this worldwide webinar, the first of its kind, and there will be more, is that the World Congress meeting, scheduled for the beginning of the fall, 5 months and 2 weeks from now, is still scheduled to be on. World Congress of Pediatric Ophthalmology and Strabismus number 5 is still scheduled. By 2 months before the meeting, we'll make a decision about whether or not that can go on. But with great optimism, we hope to see everyone in Amsterdam. With that said, I'd like to introduce Ramesh Kekanoya from India, who will introduce our panel, and we're going to jump right in so all of you can enjoy our session today. For me, it's 6 o'clock in the morning on the West Coast of the United States. For one of our panelists, Lionel Covell from Australia, it's about midnight. So from around the world in all time zones, we welcome you. Ramesh, please introduce our panelists.
Thank you, David. Again, very warm welcome to this WSPOS Worldwide Webinar 1 on Strabismus. As we have most of the delegates and participants joining from all over the world. At this slide, you can see there are panelists and speakers from 8 countries around the world. The first one is Daisy Gotts. She is a chief orthoptist in the Department of Ophthalmology, University of Antwerp, Belgium. Followed by Mauro Goldschmidt from Brazil. He is the executive director of STRABISMUS Institute, and he is also professor of ophthalmology and chief of the Strabismus sector at CFEOM Hospital, Sao Paulo. From United States of America, you just heard, David Granite is there. He is the director of Ratner Children's Eye Care Center at Shiley Eye Institute, University of California, San Diego. He is also a professor of ophthalmology and pediatrics in the same university. From US, we have Richard Hurtle. He is a chief of pediatric ophthalmology and the director of Children's Vision Center at Akron Children's Hospital, USA. From down under Australia, Melbourne, we have Lionel Covell. This is almost 11 p.m. there. It's so nice of him to join this. He is at the Director of Strabismus Service at the Royal Victorian Eye and Ear Hospital at Melbourne, which is the oldest and largest academic ophthalmology department in Australia. Followed by from Turkey, we have Çumur Şener. He's a professor of ophthalmology and also strabismologist and pediatric ophthalmologist, and he's at private practice currently at Ankara, Turkey. From Italy, we have Massimiliano Serafino. He is the chair of the Department of Ophthalmology at Gaslini Children's Hospital, Genoa, Italy. Again, from United States of America, we have Federico Velez. He is the assistant professor of ophthalmology at Duke University, North Carolina. And finally, we have Fatima Rajab. She is from Bahrain. She just completed her fellowship in pediatric ophthalmology and strabismus with us at LV Prasad Eye Institute. I now invite her to present her the first case. Over to you, Fatima.
Fatima, as you're getting your slides ready, I just wanted to remind all of our attendees that you can ask questions by typing them in on your screen, and we will see them. And as the moderators, we'll bring those questions to the panelists. Many times there'll be repeat questions, so we may summarize them and put them together for us. So Dr. Kekanoya and I will be the ones doing that.
Good day, everyone. Our first case for today is exotropia and congenital fibrosis of the extraocular muscle. Can we do better? We have no financial interest. So our patient is a 31-year-old male who presented complaining of having his outward of his left eye deviated to the left side his left eye deviated outward since childhood, and also his face deviating to the same side, turning to the same side since childhood. He has no complaints from the right eye and no other ocular or systemic complaint. Examination-wise, his best-corrected visual acuity in the right eye is 20/40 The left eye is amblyopic, with the best-corrected visual acuity is 2500. He has moderate ptosis in both eyes, with significant lag of thalamus in the left eye that resulted in conjunctival erosion secondary to exposure, as we see in this picture. External examination showed that the patient is having a significant AHP of left face turn of 35 degrees and a chin elevation of 15 degrees, as we see in this photo. In the primary position, the patient, both eyes are hypotropic, and there is large exotropia. Hirschberg test measured more than 50 degrees, and Kremesky test measured more than 100 prism diopters of exotropia. Motility-wise, the right eye was better than the left eye, with abduction and infraduction being almost full, and he has fair adduction around -2, which improves on infraduction as well. In the right eye, he had no subtraduction at all. The left eye, as we can see in the photo, was fixed in an abducted and infraducted position, and there was no movement at all. So the patient was clinically diagnosed as a case of CFEOM type 1, but unfortunately the patient could not undergo a genetic examination or a genetic evaluation. So we ordered MRI orbits with quasi-coronal cuts. In the MRI orbit, it showed that the patient is having an atrophic inferior rectus and superior rectus complex, and that is more pronounced on the left eye than the right eye, with slightly bulky superior oblique on both sides, which is also more pronounced on the left side. According to that, because the patient wants to correct his strabismus and AHP, we have planned for both eye IR resection, both eye SO exploration, nasal transposition, both eye MR resection, and both eye left eye LR periosteal fixation. Preoperative FDT showed that the right eye MR was normal, LR was around +2 tight, SR is almost normal, and IR around +2 tight as well. In the left eye, lateral rectus was very tight, around +5 to 6. Medial rectus is normal. Superior rectus is normal, and inferior rectus is also +4 tight in this eye, more than the left eye. So we have modified our surgical procedure, and we went ahead with right eye LR resection, 12 millimeters, instead of periosteal fixation as planned before. Left eye, we still have done in the left eye, we still have done left eye LR periosteal fixation due to the tightness of the LR. We've done both eye MR resection, 9 millimeter in the right eye and 10 millimeter in the left eye. And in the left eye, due to the tight IR, we have done IR resection 7 millimeter. And then we went ahead with both eye SO nasal transposition in both eyes to address the hypotropia. 10 days post-operative, the patient presented and his AHP has reduced significantly to only 7 degrees of chin elevation. But to our surprise, that the patient had a consecutive left hypertropia of 18 prism diopters, and also along with that, a residual exotropia. Also, the patient had a lower lid retraction due to the IR recession and worsening of his exposure symptoms due to the lower lid retraction and the hypertropia together. So we have decided to take the patient again to OT for left eye IR advancement with lower lid retractor release and left eye tarsorrhaphy under GA. Preoperative, if DT showed that the SR only +2 tight and the SR +2 tight and IR +1. We went ahead and we did left eye inferior rectus advancement of 5 mm with lower lid eyelid retractor release and tarsorrhaphy under GA. During the surgery, we have found also that there was significant amount of fibrosis in comparison to the timing of the second surgery. 1 month post-operative, the patient still had a good reduction in his AHP. The left face turn was only around less than 5 degrees, and the chin elevation was barely 7 degrees. 1 month post-operative also, the patient still had residual, the patient still had residual exotropia in primary position of 45 prism diopters. So coming to the questions for the panel.
Yeah, thank you, Fatima, for the wonderful presentation. I just want to ask Dr. Schenner, what is the role of genetics in your practice for congenital fibrosis of extraocular muscle, any type of congenital fibrosis?
Thank you, Ramesh. Thank you for this interesting case. The role of genetics from strabismus perspective, I believe none for the moment. So no kind of mutation would tell me what kind of surgery I would follow for this patient. The kind of surgery that I would plan is dictated by the motility pattern, the saccade responsiveness, and the head posture and the expectations of the patient. So, but the role of genetics is very important, is not just for the sake of science, but especially when it comes to reproduction. So this gentleman looks like a de novo mutation. However, if he's planning to reproduce, then he definitely needs a genetic panel. For this kind of a patient, I would start with starting with top 3 mutation first. If we are on a budget, then if there is nothing to come out, then we can go ahead with FOX2A and then KIF21A.
Can I interrupt here, Dr. Schenner? Why do you think TUB is the first gene you will go ahead? Why not the KIF and FOX? Any specific reason for that?
Okay, the reason is I wouldn't call this patient a type 1. For strabismus point of view, I don't classify them to anything. I just put them into a CCDD classification. The only classification comes through the genetics. The phenotype classification used to be from those times when we had no genetic evidence for these type of problems. So the first kind of mutation documented was for type 2, which is a FOX2A mutation for an autosomal recessive condition. And that patient have exotropia with different vertical gaze motility patterns. The eyes are frozen, and they either have a lid crotch like this while they're doing and a significant head turn. And those patients have pupillary unreactive and myotic. That's a different category, and it's less common than the rest of the panel. The type 1 is typical with the chin up. The eyes can be orthophoric with this position. Exo or ESO depends on the patient and usually symmetric. But when it comes to type 3, the patients are usually asymmetric down the line. That's an autosomal dominant spectrum, and the penetrance, although it's reported to be almost complete, the effect on the patient can be very different. If you look at the family pedigree, you'll see different cases along the line. So with this kind of a patient, what is the problem? It's an exotropia. And the head turn is much more significant than the chin up. So the chin up might be a small part of the problem, whereas the exotropia is the leading problem, which rings the bell with FOXP2A, although the pupillary reaction, as I understand, is totally normal, if that was meiotic, that would be my number one diagnosis. So the asymmetric nature, remember the left eye is frozen on out and a little bit down, and the right eye is exotropia, and the gentleman is maintaining a little bit of chin-up posture. So the condition is an exotropia, whereas the horizontal motility, remember the right eye adduction is not that worse. And when we look at the force duction test, the FOXP2A mutations, it is basically impossible to move the eyes towards the midline. I'm scared to pull, in some cases, even I disinsert the lateral rectus, I might be disturbing the retinal arterial flow. So that type. What I noticed with the right eye, the force duction tests are not too much tight that I would see, that I would expect to see in a typical, let's say, type 1 patient. In a typical type 1 patient, it's really tight. You cannot really bring the eye towards the midline from down to the midline. So my first diagnosis to rule out from this patient, from genetical point of view, although it won't change my surgical plan, is type 3. Then I might come to a decision to type 1 or type 2. The type 2, I'm getting away because the pupillary reaction is normal. The type 1, it's asymmetrical. That's a de novo mutation, and I don't have the evidence of an autosomal dominant trait there. Does this explain the answer from the genetics point?
Yeah, definitely. Thank you so much for that.
Yeah, just one.
We go to the next question.
Ramesh.
Yeah, go ahead.
I just have an extra comment. I agree in everything. I'm not going to add more than just say that genetics is also important because there are more than just the eyes. And it's not just what is going to happen to the offspring on these patients, but there are patients that have other things that are happening in the brain. And so there are more things that are related to genetic mutations in patients with congenital fibrosis of the extraocular muscles. But other than that, I mean, I think it's well said and well explained.
Do you have any comment, Dr. Velez, on role of imaging? And then we will quickly go into the surgical management of this case.
Sure.
Do you have a quick comment on that?
If you have the opportunity, I think there are very good studies done mostly by Joe Deemer at UCLA and a group of people in Korea, Kim, where actually you can see all the misinnervation and the abnormalities from cranial nerve number 3. I would say that a lot of the findings that we probably knew in terms of imaging, which was the absence also on cranial nerve number 4, or the abnormalities on cranial nerve number 4, we didn't really translate this into the clinical practice until much later. And there are really only recent publications on the importance of the superior oblique muscle and tendon in patients with congenital fibrosis of the extraocular muscle, even though we knew the cranial nerve number 4 was also affected. I think imaging is very important when planning, especially in young kids, where it's going to be really hard to do some testing in the office that can help you to know how much restriction or no restriction is present preoperatively. Now, is it necessary to plan the surgery? It's hard to know, because in reality, when you see muscle atrophy, hypoplasia, or absence, the plan of surgery is not going to change much, because it's what you have over there in terms of motility that is going to guide what you're going to be doing surgically.
Thank you for that. Fatima, can you put the next 4 questions together? I want both of you to take a minute each to explain about these questions, and post that we will take some questions from the delegates, please. Maybe Dr. can begin. Yeah.
While the panelists are getting ready to answer the questions about surgery, I'd like to just share that a number of delegates have asked about anterior segment ischemia and the use of adjustable sutures, as well as resections. So while you're talking about your surgical approach, if you could include your thoughts about all three of those.
Sure. So could we go back again to the preoperative pictures, please? I think, yeah. So the first question is, how about the stage surgery? This is a very complex situation, and the doctor and the patient must be prepared for many surgeries down the line. But in my case, most of the patients are traveling very long distances, and it's difficult for them to make it for another time. So I find myself in a position to try to finish it in one setting, as you did for this gentleman. However, the staging, why is it necessary? Especially not for this case. I'm talking about the very tight inferior rectus cases where you have to recess the inferior rectus. The horizontal deviation will enormously change. It will take an extra deviation after you release the inferior rectus tightness. So my philosophy would be to stage the surgery for the sake of correcting the chin posture than the head turn. Because once you get down with the chin posture, the horizontal deviation can change considerably, where I need to make the fine-tuning according to the first surgery's result. However, for this case, it may not necessarily be the problem. I would discuss with this patient what's his main goal is. What I see here is left eye is basically counting fingers. So we're not expecting much in terms of vision from the left eye. But he's seeing with the right eye, and the most uncomfortable thing is the head turn, which was about 35 degrees and 15 degrees chin up. So he must get rid of the head turn first. Chin up, you can deal with it. We are at the cross section there. You can either deal with it. Can I answer two questions at a time because they are related?
We can answer that two together, and then Federico can add, and then we can take few questions because we are already 23 minutes down the line.
Okay.
So
what I would do, there's the crossroads here is about the patient's response to me. If he wants just one surgery, what I would do, I would take down the lateral rectus, and I see the adduction capacity there. At the forced adduction test, it's not very restricted. So I would rely on recess and plication and offsetting the muscles upwards. I agree with the anterior segment ischemia pattern there. In these cases, also with Veres, because in these cases, it's not rare that there are absent muscles, absent severe circulation. So these people are compromised in terms of the circulation. I would keep as little muscles touched as possible in my strategy. So if he's persuaded that correcting the head turn and a little bit of the chin up, then I would do extra large lateral rectus recession, not on the periosteal fixation as you did this one, but I would do the plication much more than what you did as resection. I don't resect these patients. I do the plications. I would use 13 to 14 millimeters of plication up to the orbital septum, as you may rename it. And it is fairly easy to, with this kind of plication, to offset almost full tendon width upwards. And I would also offset the lateral rectus upwards too. This gives you a lot of upwards traction. If you want to get rid of the hypo effect, what you can do to potentiate your surgical result is to put a traction suture from the already tight inferior rectus towards in and up. I would pass a suture from with a hook underneath the inferior rectus without disturbing its circulation, and suture it towards the periosteum here with the stay suture for a few days. The right eye, it's the seeing eye. You have to discuss this with the patient ahead of time because he may have difficulty to get around without help. The left eye, my experience has been desperate. The only way to deal with this case is, as you have done, resect the lateral rectus, bury it into the tenons, and put it into the periosteum, and super maximal plicate the medial rectus. It's not enough. If he's asking for cosmetic result, the only good I can do for these patients is do a caruncular incision and place a posterior lacrimal crest fixation or in front of the medial rectus insertion with a non-absorbable suture. That's the only way I was able to achieve satisfactory cosmetic result in these cases. Other than that, just resect is not helpful.
Thank you, Dr. Kenner. I have to interrupt here. I just want a few comments from Dr. Velez, and then we can...
I have to comment because we don't have too much time in this case, unfortunately. I just feel like people have to consider the superior oblique surgery that you actually did, and David Hunter and the people at Boston have described, I think is a very important part of any surgery that we do. A lot of these exotropias and A patterns are from the superior oblique being tight or being nasally inserted. So I tell everybody who's connected today, that was something that we were not used to look for. We were always thinking that the hypotropias and the exotropias were coming from the inferior rectus and the exotropias from the lateral rectus. It is not true. Look at the superior oblique, and what you did is great because you transpose it nasally, and that actually decreased the abduction. Can actually, if you put it anterior to the equator, can cause an elevation, and you will decrease a lot of the exotropic deviation. I don't resect most of that are atrophic because, in my opinion, it doesn't work. And for the left eye, since it seemed that the inferior rectus worked because you actually got an hypertropia, an option, you can do a nasal transposition with resection of the inferior rectus muscle to the medial rectus muscle to help these patients' left eye to be better positioned. And you can get rid of the inferior oblique that is an abductor, and you can go back to the lateral rectus and get rid of it. Fixation to the periosteum does not completely eliminate function in the muscles. It's well described that the abduction from connective tissue is still present. That's it. I know we run out of time.
Thank you. Thank you so much, both of you. And I just want to summarize that many people are asking. There are 3 genes associated with congenital fibrosis of extraocular muscles. Number 1, KIF2 gene, KIF. Second one is FOX, PHOX. And the third gene is TUB. And we can utilize the imaging techniques to plan our surgery. And as Dr. Senner said, the force duction test is very, very important in the intraoperative management. And we can go to a stage surgery as well in this. And Dr. Velez gave some tips on how do we modify our surgeries. We have to modify our surgeries depending upon the case-to-case basis. There is no one answer for congenital fibrosis of extraocular muscles. We will take some questions if possible later. I would like to pass on the screen to Dr. Serafino for his case presentation. We will have to stop here with this case. Thank you so much.
So good morning, good afternoon, and good evening, depends on which part of the world you come from. So I'm going to present the case of exotropia and convergence insufficiency. It's a quick case because I want to leave space to discussion. So do something or do nothing. In the case description, this is a male, 28 years old, with history of head trauma, followed by constant exotropia and convergence insufficiency. The trauma occurred more than 1 year actually before my consultation. The visual acuity was 20/20, the exotropia at distance 20 prismatic diopters, same in left, right, up, down gaze, and the exotropia at near was 43 prismatic diopters. So as you can see, there are about 23 prismatic diopters of incomitance of difference, that it means he didn't converge at all. We should recall that the amount of convergence actually needed at 1/3 meters to maintain the same alignment as at distance is equal actually to the interpupillary distance in millimeters times 3, the diopters that we use to accommodate at near. So it means it's about 20 actually. So if you have an incomitance distance near of 20, it means that you cannot converge at all. The motility is fine, but of course the patients complain with diplopia at distance, diplopia at near, and also he is 20 years old, so cosmetic issue. So if you look at possible treatments of this condition, first is do nothing. I mean, sometimes do nothing is an option. So do nothing can be always an option. Arthur Jampolsky used to say that the lesser is the surgical indication and the greater is the likelihood of post-operative complication. So you have, it's a matter of trade-off. You have to decide to figure out what to do. And you can do surgery for angle at distance. Maybe you can try prism first. You can do surgery at near. Maybe you can try prism first. And you can use whatever technique. There are bilateral, of course, recession, unilateral resection as described in 1995 by Stephen Kraft, bimedial rectus resection, and as Lionel Cowell said in a LAT in January, hope for a good alignment or sufficient motor fusion or acquired suppression to keep single vision. I don't like actually resection in this case. Maybe we can discuss this later because to me there is a wrong theoretical construction about resection that works on the near angle. Maybe we can discuss this later. But another option, and that's what I did actually, what we did, is a bilateral lateral rectus recession for distance angle. In this case, it's 20 prismatic diopters, that to me means 5 millimeters. And the bimedial rectus elevation to create a iatrogenic V pattern. When you have a V pattern, you want to collapse the pattern. If you work on medial rectus, if you put the medial rectus down, you collapse the pattern actually. You open the V. But if the patient has no pattern and you put the medial rectus up, you can have a divergence in up gaze. That's what we want to create now. And this, as described by Ed Buckley in 2004, will help patients at near without compromising deviation at distance that we have already corrected with recession of lateral recti of 5 millimeters. Results in this case was good because he had a single vision at distance at near, no more cosmetic issues. That was one of the most important concern of the patients because he was 28 years old. They say it's understandable, right? Ortho at distance and 4 prismatic diopters at near. So the question still, and there are also other questions we can discuss, is do something or do nothing, and if you have to do something, what to do. Thank you.
let's have our panelists begin. So Daisy, since Max mentioned the idea of not doing surgery, are there other alternatives? And we'll be careful not to say that orthoptics is doing nothing, but it's not doing surgery.
Well, first of all, I would like to know a little bit more about the pre-op examination, because as an orthoptist, of course, I like to know if there was fusion or not. So I would first of all see at what point, at distance and near, we can give prisms to see if fusion is possible and measure the motor fusion. So that's one. The second, I definitely would measure the convergence, measure if there is a near, at what point your near point of convergence is and how your accommodation is. And then before surgery, surgery would not be my first option. So I will first try with prisms. If we can have at a certain point binocular single vision, I would also start with exercises, with convergence exercises, because if you can improve your convergence, then even if you're going to do surgery afterwards, it will also improve your surgery. And the better your fusion is before surgery, the better it will be after surgery, with more possibility of binocular single vision. Another option, first I would say convergence exercises, prisms, and thirdly, we have done in patients like this Botox, and also with good results. We have done it twice in patients who had no convergence at all with a convergence palsy, to wait till we could finally go to surgery.
Daisy, I've seen people with this kind of head injury lose their convergence, but later recover it with orthoptics if we waited long enough.
Yeah.
Do you think that this is with that kind of injury, is it recoverable? And are you curious about the level of accommodation in addition to the convergence?
But it was a trauma 1 year ago, a head trauma. So I suppose that there is no recovery anymore, because when it's 1 year ago, and you can, of course, if I see these patients, I would do first the examination to try to do some exercises, convergence exercises. If we can demonstrate fusion exercises, remeasure it and see if we can improve something. But as it was a year ago, I think it's already a case that you will not have a lot of improvement.
Daisy, I have a question for you. Is if you do the exercise for convergence, if it is a risk for post-op overcorrection of this patient, if he can get an ET after surgery, if you exercise a lot the convergence?
Well, in this case, I suppose, because you have like 20 prism diopters difference between distance and near deviation, so it looks to me a little bit like the convergence palsy almost. So I don't think you will have a risk of overcorrection. I think you have a risk of consecutive ET if you do too much surgery, but I don't think it will be because you did your convergence exercises, because good convergence, everybody needs it.
Yeah, there is an online question by David. There is a most common online question. How do you do a supra shift or upward shift in application? 5 or 6 people have asked this question. How do you shift muscle upwards when you do application?
Fabulous. Mara Goldschmidt, in Brazil, if this patient flew from Italy to Brazil, how would you approach the patient? And then we would like to have the panelists discuss the shift and how that's done.
Thank you, David. Hello, everyone. Treatment of convergence insufficiency and XT is challenging because of this near distance disparity, and surgery may bring distance and lateral gaze incompetence. In my practice, this convergence insufficient XT is not frequent, and I probably have less than 10 or 15 cases of intermittent exotropia with this near distant disparity. My approach is recess resect as proposed by Stephen Kraft, as Max said, increasing the numbers of the medial rectus resection. My results, the patients, they become ortho for distance and a small exophoria for near, but this is a small number of cases. And in this particular case, it's an acquired constant exotropia with convergence insufficiency and diplopia. So I would do recess resect and answering your question, but I would advise possible postoperative scenarios to the patient, which is a possible esotropia for distant, a residual exotropia for near, and maybe the need of wearing prisms postoperatively. You had, Max, an excellent result, and it's surprisingly for me the amount of correction for the near deviation. And I have questions concerning this full tendon elevation of the medial rectus bilaterally in creating a V pattern and maybe a torsional problem that your patient didn't have.
So, Max, the question's now coming up about this shift. And we've heard Maurer Goldschmidt raise the issue of the possible torsion. There's delegates listening from Baghdad, Sri Lanka, Riyadh, Boston, Egypt, India, from all over the world, asking about this shift, how to do it, and whether or not it impacts in primary straight ahead position, as well as it helps down gaze, creating a V pattern, and whether the near is measured in primary. So we have several questions about this shift, if you can help us with that.
Yeah, well, the one tendon shift in superplacing actually of the medial rectus is one tendon. One of my concerns before doing the surgery was, of course, the intorsion that I could have, after the surgery. So it was a bilateral actually. But before doing that, I have seen, I talked actually in January with Lionel Cowell that he did, several cases. And so I read a lot about that. So I saw there was no torsion, post-operative torsion described after surgery. And that pushed me to do this surgery. Patients did not complain for any torsion, of course. Maybe I think there is some cyclofusion that patient can use to overcome the objective intorsion actually after surgery.
And for Daisy, that we're getting questions again from all over the world, looking at people from as different places as Pittsburgh in the United States to Liverpool in UK. Sorry, in Liverpool for the holdup of the Premier League. And the questions that have come up are, is the central disruption of fusion that may have occurred with the trauma, does that make this patient different than a patient who might not have that problem but similar deviation?
Yeah, of course. I think fusion is very important. So if you have no fusion anymore, it's quite difficult to get binocular vision after any operation. So that's why I think it's important to improve, first of all, to find if there is a position where you can give binocular single vision by prisms before the operation. And if you find an amount of prisms you need to get binocular single vision, then to try to extend this amount of motor fusion, because if you have better motor fusion before the operation, you have more possibilities to have good binocular vision after the operation. So I think you can be the best surgeon, but if a patient has no fusion, nothing at all, then after the operation he will have double vision too, because we need a certain amount of motor fusion to see at distant, at near, in all directions of gaze single. And acquired suppression, that's something, well, normally, if we don't have binocular vision, we have diplopia, unless we had suppression in the past. So I think everything, well, it's very important to, first of all, to see if binocular single vision is possible before any treatment.
David, I would like to make a comment here. Among us, the panelists today, Federico Valles published a paper, I think it was 2 years ago, and he presented at the Claudi meeting this year, selective muscle fiber surgery algorithm for the treatment of this condition of convergent insufficient exotropia, according to the pre-op deviation. And there were subtypes of surgeries such as lateral rectus inferior marginal tenotomy, lateral rectus slanted recession, and when there is a limitation of adduction, he proposed surgery on the medial rectus. Their results on the near-distant disparity is that they reduce it to about 50%. So if Federico would like to make a comment on that, this will be great.
Yes, and Federico, while you're answering that, because it's fabulous to have the author of the study right here, people have also discussed slanting the insertion, both of the lateral and of the medial. So I'd love to hear all of your thoughts about this.
Just to make it very short, what Max just presented is based on Graefe's theory, which is probably 100 years old, and this is not a lecture. So there have been discrepancies if you have to move things up or you have to move things down. There's a lot of research done in Korea, in other Asian countries, about a slanted recession of the lateral rectus muscles for convergence insufficiency type of exotropia, which actually gave great result. And we added to that if patients have limited adduction and the force reduction test is negative, you can do a resection or plication of only the inferior third fibers of the medial rectus muscles, which in reality is like creating a V pattern. And the V pattern, which is the theory behind this, is that if you create a V pattern, you're decreasing the convergence insufficiency that is happening when you're reading in down gaze. So basically, by creating a V pattern, you get rid of the exotropia, just to make it short.
Fabulous. For all the panelists, one of the questions that's come up, and Dr. Zilan, from my old friend from Turkey, asked this question, as of others. We haven't discussed adjustable sutures. Is there a role for adjustable sutures in this setting?
Yes.
I personally prefer to analyze the tests under general anesthesia and decide where to leave the eyes. And this is my approach. I don't think adjustable sutures will be okay in the next day if the patient is feeling something and is not collaborating. So I prefer not to do adjustable sutures. Although it's a case, it's a sensorial case and sensory case, and the patient has diplopia, this is not just my experience.
Max?
Well, although adjustable suture is often an option when patient has diplopia preoperatively, it's a kind of suture that I don't like in this situation. I don't think what patients see the day after when you adjust, it could be maybe the same after, days after surgery. And also, I don't like resection in these patients, even if you do unilateral, because as I discussed with you, David, I'm convinced that resection in this case are based on the construct that resection increase have an effect on the near angle. Well, we know actually that resection increases the elastic force of the muscle, not the contractive force of the muscle. So actual resection act as a restriction. They restrict the muscle. They tighten the muscle. So if you do a resection of the medial rectus, actually you are not going to increase the muscle, the strength of the muscle, because the contractile force are not increasing, but you are increasing the elastic force. So it means that if you increase the elastic force of the medial rectus, that means that you are creating a restriction in abduction. And we use abduction bilaterally when we have to diverge. And we diverge when we look at distance. So it looks like that resection theoretically must work at distance more than near. So there is something that is not clear in the mechanism of the action. That's why I don't like that. The same for adjustable.
Max, I'm smiling because you just indicated that something in strabismus isn't clear. And I feel like that's the one sentence that describes most of my career in strabismus, that something is not clear. Rich Hurdle, you've published your work on adjustable sutures and using recessions and resections. Could you give us a moment on what your experience has been?
Thanks, Dave. In the early 90s, this was both presented at ARVO and published in the journal Strabismus on a half a dozen patients, adults with acquired low and high ACA ratio strabismus with diplopia, where we did recessions of all 4 horizontal recti in the following way. So, for instance, this patient, if they had a 50 prism diopter exotropia at near and a 20 prism diopter exotropia at distance, we would do a BLR recess for 50, which would make them esotropic at distance, and we do a BMR recess for the residual esotropia at distance, and then put one eye, both recessed muscles on an adjustable suture. And that worked out pretty well.
So, Rich, you were recessing the medial recti in a situation where there was convergence insufficiency.
Yes. You can read the reason. Yeah, the reference is available.
So the laterals for distance and the residual ESO that creates, you dealt with the medials.
Right. And
so
you can do it with low or high ratios. Either way, it works.
Great. Shimura?
So I was wondering about this flap tear philosophy. I mean, this is a trauma case. What evidence do we have about the cause of the acquired convergence insufficiency in this case? What can be the reason? How many of you have witnessed or documented a flap tear in this kind of a case? I did, and I had to fix it.
Yeah, I'm from a personal standpoint, I've seen 3 football or soccer players hit in the head. I don't know why so much there, not as much as in American football where they get hit every play, but I've seen 3 football players get hit in the head and end up with a situation like this. Max, what was the injury?
It was a head trauma, actually. He fallen down from a terrace. So it didn't have a trauma of the orbit, so I didn't think to the flap tears. And I thought was acquired because of neurological injury.
Fabulous. Ramesh, I think we probably should move on to the next case.
Yeah, sure, David. We have some more than 100 questions. If you have time, we will answer now or later. So we can go to the next presentation.
Well, if you have one or two that you want to get through, that's great right now, and
Yeah.
then we can move on.
Yeah, I have one question. I think this is from Preeti Patil from Pittsburgh. This could be for Daisy. What's the minimum angle of convergence insufficiency with response to exercises?
I think you can always do exercises as long as any convergence is present. So those people who have a convergence insufficiency that is, for example, that they cannot converge till 50 centimeters till 1 meter, you can still try to do the exercises. I think you have to start with your convergence exercises to see if you can improve something, especially when it are traumas, with more recent traumas. I have had 2 patients with a convergence paralysis after a head trauma, and we tried with exercises, but there was no convergence at all, so we couldn't do anything. But I think you have to try it to see if you can restore any of the convergence. So I would always do it if this patient who had like 20 prism diopters at distance, so probably he or she had already an exophoria before that. You had an angle at distance increasing at near, but you can first give prisms to get one single image and then try to do the exercises. That's important.
Thank you, Daisy. Thank you for that. When Rich is going to present now, I just want to tell the panelists there are 3 important questions asked. One is, what's the role of botulinum toxin? What's the role of vision therapy? And what are the chances of central fusion disruption in this case? So as he going on through the next presentation, at the end, panelists can give the answer for that. Rich?
Yeah, we'll come back to that. Rich, before you begin, just one housekeeping thing. For those of you watching online, there are 3 main places to watch. The web link, on YouTube, and on Facebook. If you're having trouble with one of them, you can try one of the other 2. We're getting feedback that in some parts of the world, one is working better than the other, but it's not the same one. So please feel free to try, and you can switch from YouTube to the Facebook Live to the web link if you're having trouble on one of them. And we literally have we have people and experts from around the globe who are joining us online. So we're excited to see you, and please keep asking your questions. Rich.
Thanks, David. It's a pleasure to be part of this, and hopefully we'll work out the kinks in this first one so that many of the others will go smooth. We appreciate you taking the time out of your COVID isolation to spend with us. This is a 10-year-old I saw in consultation from out of state who had an alternating head posture and came to see me for a consultation regarding that, and wound up having what I think is probably fairly common, that many people around the world see patients like this. This is a child with a long-standing history of strabismus, and I'll walk you through our diagram. This is the patient facing us, and he had 20/80 in the right, 20/70 in the left under monocular conditions, and 20/30 under binocular conditions. With monocular cover, he turned his head to the right and with the right eye fixing, and turned his head to the left with the left eye fixing. The rest of his exam was normally, had a little bit of myopic astigmatism. He had a pretty competent 20 prism diopter constant exotropia at distance. At near, it turned to an intermittent exotropia with fusion. He had some good fusional verdance amplitudes too. So he was behaving like a monofixer at near, and binocularly at distance, he had no diplopia, but he had alternating fixation, although he preferred the left eye with more of a left face, but he switched between left face and right face. And at near, when he was fusing, he did not have a face position. When he broke down again, he switched between right and left face. He had a constant clinical nystagmus, which was a small to moderate amplitude moderate frequency jerk right and right, jerk left and left, a small amplitude predominantly jerk left in primary position. He had a large latent component when covering the eye. It switched and changed to jerk left with the left eye viewing and jerk right with the right eye viewing, with decreased intensity in adduction. Eye movement recordings showed a typical latent nystagmus or fusion maldevelopment nystagmus syndrome picture with decreasing velocity or linear slow phases. And so the parents asked me, just like I'm going to put out to the panel, what do we do for this patient?
So this case involves two of the last keynote speakers from the World Congress of Pediatric Ophthalmology and Strabismus, Rich Hurdle and Lionel Carville. So Lionel, I will humbly defer to you because I always learn every time you speak. So I'd love to hear you go first.
Well, David, it's there's only one way off a pedestal, and it hurts. Rich, these are tough cases, aren't they? The only way we can improve his face turn to the left is to substantially interfere with his adduction in the left eye. The only way we can improve his face turn to the right is to substantially interfere with the mechanical process of adduction in the right eye. And that's going to make his exotropia terrible. But that's what we have to do. I think I would do a large bimedial recession, augment it with something like a Farden. My preference is medial rectus pulley suture. And you need to cripple adduction in order to fix his face turn. That's going to make his exotropia terrible. And you then need to do a simultaneous, very large lateral rectus recession, and then see what happens in week 2 to 4. If you have undercorrected his original plus iatrogenic exotropia, you'll need to do more. And if you have overcorrected it, you'll need to reverse it. I can't think of another way to improve this boy's alternating face turns and give him normal appearance. What did you do?
Rich,
Dave, you want to go first before I tell you what I did?
Yeah, because I knowing you, I think that you put a couple of things in here that were interesting for discussion. Right off the bat, you have someone who has two different head positions, and the doctor looking at this patient, you've made it easy because you did the recordings, but the doctor looking at this patient has to be concerned about PAN versus fusion maldevelopment, which I love that you have called fusion maldevelopment nystagmus syndrome, to remind all of us that it's not just nystagmus, that there are all these other things that go along with it at the same time. And as Lionel said, you're looking at, the child is adopting the eye in adduction. It's not truly a gaze position. It's putting the fixating eye into adduction and separating that out. FMNS from INS will give you a different concept in how you approach this patient. And then finally, you made this patient have fusion, which is really important in someone with fusion maldevelopment, because fusion helps decrease the nystagmus dramatically. And so we're trying to play into the patient's fusion. We're trying to defeat the head position, which if you had given us amblyopia and one eye and one head position, we could have operated for that head position on the fixating eye in adduction, and then taken the remainder of whatever the deviation is, calculated it, and fixed it by operating on the other eye. But you've given us this alternating head position where both eyes like to be used, and it's a fascinating conundrum. And I would have approached this very much like Lionel did, which is you end up, if you're going to let the child still fixate with the either eye, then you end up recessing the medials in both eyes and recessing the laterals for what's left over, similar to what you described earlier in the convergence insufficiency. My concern is this child fuses, and are we going to change the way this child functions in the world by doing such large recessions? Are we going to affect the child's ability to look both at distance and near, especially with child having fusion now at near? So I'm very curious to see what you did.
All right, so I'll tell you what I did and why. A BLR recess and over minus spectacles. And because the child has fusion, and when he's fusing at near, he doesn't have a head posture when he's fusing. So I wanted to promote fusion. And I promoted fusion by reducing his strabismus angle and doing orthoptic VT and also over minusing. So that increased his fusional vergence amplitudes, keeping him in his monofixation. During his monofixation sensory status, he doesn't really adopt the head posture. He's staying pretty straight. So I just treated his strabismus.
So both of us failed to ask you what his head posture looked like at near.
I have it there. Distance worse than near.
For distance, it was how bad? 15 degrees, 25 degrees?
20 exotropia at distance and 20x. Oh, you mean
sorry, his face turn in degrees.
Yeah, well, it changed depending upon how hard he fixated.
So if you got him to read the lowest line he could manage.
Yeah, then he was all the way in adduction, like 40 degrees, 45 degrees.
A huge face turn, 40 degrees or more.
Yeah, when you patched him, because the nystagmus was so intense, he had to go all the way in adduction. When he broke down spontaneously, that's a little bit like fogging, then his head posture was less. So the head posture depends on the intensity of the nystagmus and how far he has to put the eye in adduction to decrease the intensity.
Rich, in my experience, when the head posture gets that extreme, people don't use it unless they're forced to for vision, that they would actually take less clarity in the vision than turning their head 40 degrees and function that way, unless they're forced to try and read something.
All kids with anomalous head postures will choose over the period of their development, usually in the first 3 to 5 years, to make a choice between neck and head. Do I feel better or see better? Most children will choose to feel better and not see better, which gives the clinicians the delusion that the head posture goes away. It doesn't go away. They just use it less, or they'll use it to grab the world and then stop. So watching children with anomalous head postures, even from diplopia early on in infancy, many of them will choose to try and suppress and get rid of it. So watching a child with a head posture over the course of years, in most cases, it will appear to us as though it's getting better. And the reason for it doesn't get better, the child just suppresses and doesn't want to use their neck, face, back, and spine to see well all the time. Plus, it shuts off their visual field.
So really,
there is a question from Taiwan. Does the child have any dominant eye?
Yes. If you look at the acuity, the left eye is the dominant eye.
But you did tell us that he will alternate fixation and alternate his face turns.
Right. So it wasn't so dominant that, from a sensory point of view, he has better acuity in the left than the right. That may verge on being amblyopic. I'm not sure one line with monocular occlusion in an nystagmus patient fulfills all the criteria for amblyopia, but it could be. I don't see any reason why it shouldn't be different in adduction in both eyes under monocular occlusion. So I think he's got a little bit of amblyopia in the right eye, prefers the left, although he'll alternate fixation between right and left.
Rich, for the purposes of discussion, let's pretend that this patient was now 45 years old and just came to you. And you used an over-minusing strategy. Let's have this person now be presbyopic. What would you do?
Yeah. I don't do over-minusing. This is about the max preteen, sometime in the first decade.
So then the same patient is frustrated and comes to you in a presbyopic age. What is your strategy?
Oh, I would do the same surgery. Orthoptic therapy works. So vergence therapy, not over-minusing. I have, a partner who does orthoptics with me, and there's 3 stages. And the 3 stages we use in our office you can read about them in the CITT trials, the Convergence Insufficiency Treatment trials, the 3 stages of binocular vision and accommodative therapy are implemented in our office over the course of 12 weeks. So a lot of the adult patients I have who've been strabismic for a long time do pre and post-operative VT. So I would do orthoptic vision therapy and a BLRSS, even in the adult. The key here is I would do the operations you guys said if there was no fusion and constant alternate head postures. Then the BLRSS would be the alternative. That I would have to do. I agree. But the key here is that the patient has fusion, and the goal of treating the nystagmus and the strabismus and the head posture in patients with fusion maldevelopment and
to maintain fusion
is to promote fusion. That's the key. That's the guiding principle. If they don't have fusion or fusion's impossible, then it's more of a mechanical fix. I'm just building on what Daisy has been saying. Fusion is the thing that makes us look like we're good surgeons or bad surgeons.
And the fact that the patient has nystagmus doesn't change that. It doesn't change your ability to use over-minusing or orthoptics. No. Daisy, while we have you on the panel, is there anything special that you have to consider with someone with nystagmus, or is it we should all be thinking about using orthoptics when it's possible?
We know that these patients, when they converge, those with the congenital nystagmus also, when in convergence, your nystagmus is much less. So I think, and at near, he is better too, because then he can cope with his XT. So he is accommodating accommodating, converging, and to correct his XT. So, and then he has less nystagmus. So I think at distance he has no fusion because he has a manifest exotropia. So the fact that to improve his fusion will reduce his nystagmus, will reduce his head posture. So I think also in this case, fusion is important. And of course, it depends if you can improve it or not.
Lionel, Lionel, I wanted to ask you something. In that Rich does a huge amount of eye movement recordings and gave us already that this child had fusion maldevelopment, which implies a decreasing slow phase or a linear slow phase. You know, that's hard to see when you're just looking at a child. If you don't have eye movement recordings and you're trying to separate out whether or not this is fusion maldevelopment or this is INS, how would you suggest people look at that?
Wow. Well, I also have eye movement recordings available, and I also have Rich Hurtle available as a backup to interpret the eye movement recordings. Thank you for helping me for 25 years.
And I have to admit that I was taught nystagmus by Rich Hurtle, so everything I know about it I learned from Rich also. So we are disciples.
And I've compared my own in-office assessment of is it INS, is it FMN, or is it a combination. I've compared that with what the eye movement recordings show, and after doing this for 25 years, my results are about the same as when I was doing it for 5 years, and that is I'm right a little bit more than half the time, and I'm wrong nearly half the time. I think it's very difficult to sometimes tell the difference between the adduction null of FMN and the convergence null of IN. They can look very similar. Do you agree, Rich?
Absolutely. I think the only way you can tell exactly what type of nystagmus you're dealing with is to do eye movement recordings. And I know it sounds silly, and I've been saying it for 30 years, but the cardiologists have been doing that with their arrhythmias of the heart for 100 years. You know, they don't put their fingers on the pulse and say, oh, this is a type 1 AV block, I'm going to give Inderal. That's perfect. You know, so if you really want to know what type of nystagmus the patient has, if you're interested in diagnosing the nystagmus, it can only be done with eye movement. I don't care what your eye.
And half the time, or a little more than half the time, I am correct in my office diagnosis, but I still regularly get it wrong.
Well, is half enough to do clinical medicine? So if I diagnose the cataract half the time, exotropia half the time, retinal edema half the time, orbital tumor half the time, is that reasonable? I agree with you. I think we can diagnose a lot of things without the equipment. Do I need an OCT to look for cystoid macular edema? No, half the time I can diagnose it. So my point is that's not good enough.
In other words, the office diagnosis is about as successful as marriage. Is that about right?
Yeah, at least the first 5 years.
Wow. Well, I'm not sure what I can add after that.
I have to take off.
All right. Well, we're wrapping up right now our session. We have some questions that have come up, especially about the second case, and we want to throw it open to the panel in the last just few minutes that we have. If there are any comments anyone wanted to make that we didn't have a chance to make thus far.
Someone asked about doing plication and vertical offsets at the same time. I've seen Matthew Pilblad from Pittsburgh present a technique that I have yet to do one, but it looks attractive and sensible. Federico, have you seen that technique?
Yeah, absolutely. You can actually, it's kind of a transposing the muscle without disinserting the muscle, just plicating one pole, and then you just drag it superiorly and anteriorly. Absolutely. Yep. It is actually something that we frequently do for different conditions.
Good.
We've had a lot of questions. One thing I'm going to ask all of the delegates watching is to let us know what other topics you'd like to hear discussed. Obviously, we'll have strabismus back again, and what we tried to do is pick a potpourri of various different types of strabismus. But please tell us what you'd like to hear. We can arrange more of these types of conferences. If you liked it, if you didn't like it, what you liked. If you didn't like the panels, you didn't like me, it's all fine. We want to hear from you and let us know what you thought. Federico?
Can I ask a question to Rich? I don't see him.
Oh, Rich unfortunately had an emergency that he had to leave for, so I apologize for that.
Thank you.
Max, was there anything you wanted to add about your case? You're still muted.
Yeah. Well, I don't use the technique of Matthew. I know that's that technique of application and upshift. So I don't have results about that. I think it could be reasonable to use that. I don't have anything to say.
Shamor?
I was going to ask to Rich, but he left, so I will forward my question to Daisy and Max. What's the role of prism adaptation before you decide about the kind of technique you're planning for this kind of patient? We're talking about the acquired XT, or we can extend to intermittent XT if you like.
Well, I personally don't use the prism adaptation. If I'm talking about the intermittent XT, I used to patch the patients actually to see if to see the maximum deviation. But in these cases, I don't use that. I would use the not prism adaptation, but just in office prism to see if the patients can fuse actually. But to decide if I can operate on the distance angle of the near angle, just for that actually. So I put, I don't know, 20 diopters, prism diopters, that is the deviation at distance, and see what happens at near. So maybe I can figure out what to do to the distance angle and the near angle.
Could that be the answer of your case about it's a very successful outcome and surprised about it. It's just 5 millimeters recession and dealt with 43 prism diopters of XT at near, which I have never been able to achieve.
Well,
so the basic reason why Kirshner and Buckley has suggested about this offset is just creating a 6 or 7 prism diopter of D pattern advantage, nothing more than that. So it shouldn't be explaining the additional 23 prism diopters that you can achieve with 5mm recessions. I mean, the offsets theoretically should not put any input to primary position near deviation. So what I'm saying is he had strong fusion capability. So just putting him in a little bit into the fusion range, the problem has been solved. So the other part of the question arises. I don't think offsets has done anything in there.
That could be an answer, because I know about the 6-7 maybe prismatic diopter or B pattern or iatrogenic B pattern that you can create with this technique. So maybe if this was not able to fuse, it's pretty impossible to reach these results. Maybe you can correct less, I mean, at near.
Sounds like
Ash, did you have a comment? Oh, go ahead, Lionel.
It just sounds like a good topic for a multi-center study, Jamur. What do you think? You may only expect to get less than 10 diopter effect in primary, but patients read on down gaze, and you might be getting a bit more than that on down gaze, and that's what makes them happy. And if they're starting off from a position of better fusion on down gaze, then their primary position measurements will be better.
So we just have a moment left. Federico and Ramesh, you each had a comment.
I just want to call the attention that you can get that much of correction because the people from Asia found that even a 1mm slanting corrected 8 diopters per muscle. So if you look at the comportamental theory that Joe Dimmer is kind of work on really hard, it may explain why doing this kind of slanting procedures can correct such a large deviations in some specific gaze position. It's theoretical, but it's...
Yes.
Yeah, Max?
Ramesh?
Yeah.
May I ask, how was the convergence after your operation finally?
Excuse me?
How was the convergence of your patient after the surgery?
Well, I checked the chart. I have just the measurement for the distance at near at distance. I don't have all measurements. They are on the hospital. I can't catch all the chart right now in the hospital.
Ramesh,
David,
last comment.
Yeah, I'll make a last comment because there are a lot of questions on the first case. Number one, the first question is, why did we operate on both eyes? I think his abnormal head posture would have been corrected with just right eye, but patients always want the cosmetic correction as well. So it's a combined decision to tackle both eyes. Second thing is, there is a question about what is the risk of anterior segment ischemia. Yes, always there is a risk of anterior segment ischemia, but in our experience, especially in young patients, we have even published the same results of 77 patients in Strabismus journal. You all can go through it. When the muscles are healthy, when the systemic conditions are okay, we can also do 3 muscles. This is again, if you ask 100 strabismologists, maybe 30 will say no, and maybe 70 will. So this is a controversial topic. I don't want to dwell in too much into it. The other suggestion, the third and the last suggestion was, when we do a bilateral inferior rectus recession, it's also a good idea to transpose it nasally. I totally agree with that comment. I think we should do that. And with this, I think it's time to wrap up. Maybe David can say his few words, and then I just want to say 1 or 2 sentences and we'll close this.
Yes. So first off, we were all part of history today. This now, I believe, officially becomes the largest meeting related to strabismus and pediatric ophthalmology in the world with over 2,700 delegates on all platforms joining us. So congratulations to all of you during the COVID quarantines for joining us to add to your experiences as doctors to help others, which is really what we're all about at the World Society as well. We look forward to seeing everyone in 5 months and 2 weeks at the World Congress meeting in Amsterdam, and we'll let you know if that changes for any reason. We will have more of these meetings online as well. If you want to follow us on the Facebook page for WSPOS, please do so now. If anyone's interested in joining the Pediatric Ophthalmology International Listserv, email me directly. It's the only way to get on, and my email is dgranit, my last name. So it's DGRANET at UCSD, which is my university, UC San Diego. So it's dgranit@ucsd.edu to join the International Pediatric Ophthalmology Listserv. So this part of history, we're going to need to tie up. I'm going to toss this to Ramesh to end, but we all want to get to have better numbers than Lionel discussed for our marriages, for those of us who are marriages, and do better than 50% and return to our families. Ramesh, I'll leave it to you to close as I say thank you to all of our panelists.
Thank you so much, David, for that final words. I just had one or two housekeeping things. People who wants to join a Facebook of WSPOS, they can always join. We have a Facebook. We discuss some of the cases, and it's always good. And you all can become a member of World Society of Pediatric Ophthalmology. It's free for all. There is no membership fee. I encourage as many of you possible to become a member. With a lot of learning there, we have a lot of videos, a lot of teaching material. And finally, I really want to thank all the participants across the world. I hear there were 38 countries represented with close to 2,800 people. Thank you so much. And most importantly, I would like to thank all of you, all the speakers and panelists. And Lionel is just about to go to bed. It's almost 12:30, I guess, there. Thank you so much, everyone. And finally, I would like to thank the Entod Pharma for providing and hosting today's program. And they provided a beautiful platform for all of us to learn. And the last thing is, we had more than 120 questions. We will try to send it to all the panelists, and we might make a PDF file of that so that we can answer most of the questions which are relevant to this symposium. And with that, a big namaste to all of you. Thank you so much for being a part of this. Thank you, everyone.
Thank you, Ramesh, and please enjoy your day or your night, wherever you are in the world. We look forward to seeing you again next time, because expertise resides all around the world. God bless everyone. Bye.
Bye-bye.
Stay safe.
166 questions.
Thank you so much, Raman and the team, and Entod, Puneet, Mr. Nikhil, everybody. It was a fantastic thing. Thank you so much for everything what you have done.
Pleasure.
And I'm getting Alpesh. Thank you, Alpesh, as well.
Thank you.
Thank you, Ramesh and David. And
Awesome.
Ramesh, you've been such a hardworking person. I mean,
thank you so much.
Under those lockdown days, and also your fellow, thank you for taking all the trouble to bring us together. It's a very enjoyable meeting. I learned a lot. Thank you all.
Thank you so much.
Yes,
we will leave the meeting now. Thank you.
Thank you.
Shukriya. Namaste.
Bye-bye.
Shukran. Obrigado.
Good night, Lionel. Good night.
Laila Tov, Lionel.
Laila Tov.
Ciao, Lionel.
Buonasera. Buonanotte.
Buonanotte.
That's it. I'm going now.
So,
Bye.
Lionel, Max, since we are still here, Let me know when are you allowed or will be able to return to surgery in your places, in your hospital?
So far, not before of June.
We
So
are
in May,
starting 25% of normal surgical load next week.
oh,
Oh,
no,
25%.
May, absolutely not. Maybe June, maybe.
Okay.
So we're starting next week.
Next week.
But we had serious lockdown from the beginning. We stopped flights from China in January, and our mortality rate is 3.5 per million.
Wow.
Belgium is over 500 per million. And our government was very aggressive, and it's probably been sensible.
Yeah, absolutely.
Good to hear that.
Yeah.
Okay, folks.
Okay.
Okay.
Ciao.
Laila Tov.
Laila Tov.
Buonasera.
Buonanotte. Thank you.
Ciao.
Buonasera.
Bye-bye.
Buonanotte. Ciao. Buonanotte.
Bye.
Ciao.